Heart failure is a situation where there are many adaptations from the neurohumoral mechanism, which include many of the systems which are shown here. In the next 7 minutes, I'll be talking about renin-angiotensin-aldosterone system and natriuretic peptides. As you all know, RAS system in heart failure is activated. Many of the factors which stimulate renin release is activated in heart failure. There is increased local synthesis of angiotensin 2 in different tissues. All this lead to increased aldosterone levels and increased ADH. All this lead to vasoconstriction, increased sodium and water retention. We have AC inhibitors and ARB, which can inhibit RAS in heart failure. And we have n number of RCTs showing that AC inhibitors are beneficial in heart failure. It reduces total mortality and hospitalization for heart failure. And this has led to the current recommendation which has given a class 1 indication for AC inhibitor by the ESC. ACCIH guidelines says that if you cannot give an ARNI, AC inhibitor is a class 1 indication. Let us have a look what ARNI is. Natriuretic peptide system consists of mainly 3 polypeptides, A type, B type and C type polypeptides. They have 3 receptors, again A, B and C. They act by increasing the glomerular filtration rate, leading to natriuresis and diuresis. They decrease the renin release. They have some direct vasodilatory action, some direct sympathetic inhibitory actions also. They are degraded by either receptor-mediated degradation or a breakdown by extracellular proteases like neprilysin. So, natriuretic peptides, they oppose most of the non-biological effects of the angiotensin 2. Natural increases in natriuretic peptide, even though they are beneficial, they are ineffective in alleviating the fluid overload which occurs in heart failure. So, we now know that having a higher levels of natriuretic peptides may be helpful. So, the possible strategies include, we can give an exogenous natriuretic peptide like nesiritide, which has initially proven to have some benefit in acute decompensation and heart failure, but which has gone out of favor because of renal dysfunctions and hypotension. Or we can have a pharmacological enhancement of the endogenous natriuretic peptide by, for example, by inhibiting neprilysin. So, neprilysin has more than 50 substrates in the body. They act on vasodilatory peptide, they also act on vasoconstrictory peptides. So, if we inhibit neprilysin, both the vasodilatory peptides and the vasoconstrictory peptides will go up. If the vasodilatory peptides are more, it causes decrease in blood pressure, decrease in fibrosis and myocardial hypertrophy. But if the vasoconstrictory peptides predominate, it has the opposite effect. So, the initial studies with pure neprilysin inhibitors, it didn't show much of a benefit because of this thing. It increases the vasodilatory peptide, but along with that increases the vasoconstrictive peptides like angiotensin 2. So, we are thinking of ways how to deal with this increased angiotensin 2. Then came studies with neprilysin inhibitors with AC inhibitors. Even though it significantly reduced blood pressure, there are increased risk of angioedema and airway compromise, basically because of increased bradykinin. Then came the combination of angiotensin receptor blocker with a neprilysin inhibitor. The neprilysin inhibitor will increase the levels of natriuretic peptide, and the valsartan, the ARB, will block the effects of angiotensin 2, which leads to the beneficial effects of ARNI like vasodilatation, decreased renin release, decreased blood pressure, and other beneficial effects. So, if you look at the studies of ARNI, the Paradigm Heart Failure was a landmark trial which included patients with class 2, class 3, and class 4, which ejection fraction less than 40%. The primary composite endpoint was outcome was composite of cardiac death from cardiovascular causes or hospitalization for heart failure, which showed that there was a highly significant 20% reduction in primary composite endpoint of cardiovascular death and hospitalization for heart failure, but also an increase 16% reduction in death from any cause. So, ARNI doubled the beneficial effect of cardiovascular death compared to AC inhibitor, and ARB, this is compared to candesartan in the CHARM trial and enalapril in the SOLVE trial. We now have ARNI trials in different spectrums of stage C heart failure. We have Paradigm Heart Failure in chronic heart failure with reduced ejection fraction. We have Pioneer HF, which was done in patients with acute decompensated heart failure. In Pioneer HF, we showed that ARNI led to a greater reduction in NT-proBNP compared to enalapril. We have the live study which was done in patients with advanced heart failure, but it was a negative trial. It showed that ARNI did not reduce pro-BNP or clinical outcome when compared to an ACE inhibitor. And some analysis of many of the trials has shown that ARNI is probably beneficial when the ejection fraction is low. As the ejection fraction goes up, the benefit of ARNI comes down. So this has done to the recommendation of the dictum is, when you have any doubt, you trust the guidelines. So let us see what the guidelines say. ARNI is recommended as a replacement for ACE inhibitor in patients with heart failure with reduced ejection fraction. This is the ESC 2021 guidelines. The ACEI 2022 guidelines says that in patient with symptomatic heart failure with reduced ejection fraction in class 2 and class 3, you should change to ACE inhibitor or ARB. But the 2024 ACEI expert consensus says that for indication for use of ARNI in heart failure with reduced ejection fraction should be given in patients class 2 and class 4, and it should be used in place of ACE inhibitor or ARB. Sacubitril should be started in a dose of 50 milligram twice daily, except for in patients who are taking higher dose of enalapril or valsartan. You should start with a low dose, increase at 2-week interval. Some elevation of blood urea or serum creatinine may be there after starting sacubitril. You can try decrease in the nephrotoxic drugs or potassium supplements or diuretic. If the rise in creatinine still persists, you can half the dose of ARNI and do a recheck after 1 to 2 weeks. If the potassium rises to more than 5.5 or GFR less than 30, ARNI should be stopped. There are some of the contraindications where you cannot give ARNI in pregnancy, lactation. If you are taking a ACE inhibitor, you should wait for 36 hours before starting ARNI. Any history of angioedema is a contraindication. So take-home message include ARNI is recommended as a replacement for ACE inhibitor in patients with heart failure with reduced ejection fraction. It can be started in both subacute and chronic settings. The benefit of ARNI is seen in those patients who are already taking those drugs which has mortality benefit in heart failure.